Hey everybody, I'm going to wait a couple seconds to get started here. Tonight I'm going to be going over returning to running, or really any sport or activity after injury. This is geared both towards docs and patients, so there'll be some things for my colleagues out there that seem pretty basic and common knowledge. And for the patients, there may be some things that don't directly apply to you, but just like anything else, I think it's always good to really educate yourself as best as you can. Also, during this, if there's any questions, please feel free to ask or comment on here. I'll try to do my best to answer them. I may wait till the end to answer some of them. Like I said, the same to both docs and patients. I see a lot of runners. We're pretty tied in with the running community in Birmingham. That being said, I'm focusing on running because if you're a runner, you treat a runner, you know a runner, you can probably kind of commiserate with the runners are notorious for running through injuries to the point where they run themselves out of running itself. And I'm a runner too, and I've been guilty of it as well. And I mean, I know better than anybody. But that's why I wanted to go through this. And before I start, I'm going to post this video just like my last video. If you didn't check the last video, it was on the 3 levels of placebo. All these videos, all the Facebook Live videos every Sunday night are going to go on my YouTube channel as well. So go check that one out. I don't know if you're going to be able to see this. I feel really ridiculous doing a giant whiteboard, and I think this is backwards for you guys. But basically I have a chart of what I'm going over that kind of shows the flow and the cycle of proper, and I say proper from my standpoint, return to play. But that chart will be in the comments. You can take it if you're a clinician, you can take it if you're a patient, you can use it. I'll also talk about that, or maybe post a separate video. But anyways, to start, the top of this cycle obviously is running or your sport or whatever your activity is, and that doesn't mean it has to be activity. That could just be everyday life. But from the normal activity level, and I'm going to use running from now on, whenever we're running, injury is going to happen. I don't know, maybe there is a runner out there that has ran their entire, his or her life with no injury. I highly doubt it. Especially nowadays, the way that our kind of everyday lifestyle lends itself, we're just not built to run, especially run distance, without eventually having some sort of injury. So once that injury has occurred, from my standpoint, we have to determine, is it usually in running, it's going to be an overuse injury, which means that we run into things like tendinopathy, tendinosis, bursitis, stress fractures, things from movement like running of a repetitive nature where we basically just wear ourselves down. Now, my first caveat of an overuse injury is I don't know if there truly is an overuse injury. I would say there's an injury from using the improper mechanics too much. I'll pull up the study and try to put it in here, but there was a really cool study looking at basically the cartilage matrix in the ankle and the knee, so the meniscus, and then between the talus and calcaneus, how the cartilage regenerates for a long distance runner. It actually showed that if we stayed at a moderate pace and we had almost ideal mechanics, that we would constantly be able to regenerate cartilage on the move. So if you're a big running nerd, that lends itself to maybe confirming some of the old theories of like endurance hunting and how we evolved. Who knows about that? But there's really interesting stuff saying that if we have really good mechanics, that our body can handle basically moderate loads over long periods of time with not much duress. But when the mechanics start to break down, that's where we're going to get an overuse injury. When we have an acute injury, which I do a lot more trail running than I do just pounding the pavement. So things like ankle sprains, I mean, you can have, step in a pothole, meniscus injury, but we're talking acute injury, a broken bone, you fall down the hill, whatever it is. Rarer in running than it is in other sports, especially contact sports, but it does happen. Now, the third injury category from running, and again, I'm just using running as an example here, would be a chronic injury. So a chronic injury can happen from either an overuse or an acute injury that basically does not go through this cycle that we're about to talk about properly. And I'll go ahead and start going through the cycle. We'll come back to chronic injuries. So after we've had an injury, mainly an acute injury, healing has to take place. It depends on what the injury is, to what extent. So this is a really hard thing to just give a point blank answer, but a soft tissue or osseous injury, usually, if we follow the normal healing cascade, is going to take about 6 to 8 weeks to heal. Now, my job and your job as a runner or a patient is to try to speed that up as fast as we can. So if we have a true acute injury, we've had tissue, basically derangement, we're not fixing anything unless it's a surgical intervention. I've completely, grade 3, I've blown my Achilles out. I mean, yeah, that's a surgical intervention, but then we still have to heal that surgical intervention, which still follows the same healing cascade. So my job is to help speed that up with, passive intervention, whether it's, things like, electrical interventions, Mark Pro, different types of soft tissue like Graston, whatever it is. But there's all sorts of literature out there that say we can speed the healing process up, but also what we can help with is basically how your motor cortex is adapting to the way that you're moving while you're injured. So, for example, like an ankle injury, we see a lot of people that have altered mechanics or limp long after the ankle should be healed from this healing matrix standpoint, and that's probably because your brain becomes hardwired to maintain that limp. I always equate this in the office to if I was a caveman, I was running, I sprained my ankle. My only job from my brain standpoint is to keep me moving forward. It doesn't matter how good the mechanics are. I just have to be able to evade a predator and catch my next meal. So there's nothing in my brain that has to set me back to square one, and that's why I have a job, right? And any other rehab, physical therapist, any of us have a job is because on its own, the body and the brain usually do not default to proper mechanics. They just default to good enough, which usually leads to a chronic injury if the good enough is not good enough to get us through the activity for said, period of time or race or whatever that is. So we went through the healing cascade, and this is where there's going to be a little crossover, but after healing, we're going to, in my eyes, start treatment. So of course, treatment is taking place during healing, but just like I said, I can't, this is more from my clinicians, but obviously we look at how do we progressively overload tissue to, properly heal something, how much time do we have to take off if we have something like a fracture or stress fracture. But true treatment to me, for the people that I see, I'm not usually seeing acute injuries. I'm usually seeing people that are either chronic or overuse. They are obviously still mobile, they're in a lot of pain, they may not be able to run or do whatever activity. So treatment to me is where we're trying to get that person back to square one. We're trying to get them to be able to run pain-free. We're trying to get them to be able to pick up their child pain-free. And if it's not pain-free, we have to improve the mechanics enough to where they have a chance to get out of pain down the road because their brain is positively adapting to the way they're moving, but also the environment that they're in as well. So how can we go from treatment back to that chronic injury? So we have the healing loop can take us to a chronic injury. And that would basically be if I don't take enough time off, I get back to running too quick, I'm going to go end up in a chronic injury. I could end up in another acute or another overuse. So actually letting things heal if we've had trauma, which that's a big deal for a clinician to pick out. Do I have an injury or do I have a chronic, basically hardwired pain pattern in the brain that's what I'm treating, or I'm treating a true injury, which, like I said, more often than not, I'm not treating true tissue, bone pathology. I'm treating the brain. So from healing we get to chronic, from treatment we get to chronic if we do not have appropriate treatment, timely treatment, and effective treatment. So my job is to first figure out what's wrong with you, figure out what kind of injury we have. If your injury is within my scope of practice, once we've done that, I have to pick the appropriate treatment. I have to perform it timely. So again, we can talk about progressive tissue overload. We can talk about the correct exercise prescription, and it also has to be effective. So this is where I personally believe that we go back to that placebo talk from last week, the relationship I develop with the patient, my proficiency at the techniques that I pick to choose, or that I choose to treat the patient with, those all are a big deal. And that's why, I'm just being honest, there are doctors that are better than others. It's because they can put all of the pieces of the puzzle together to be a little more effective, hit the nail on the head diagnostically, have better relationships. And if you can put all those pieces together, your overall outcomes are just going to skyrocket. So it's not to say that somebody that's super smart is always going to be the best doctor. Somebody that's technically sound is always going to be the best doctor. You got to have a couple things going on, I think, to get the best results. But if we don't have appropriate treatment, timely treatment, effective treatment, we're going to go back through this chronic cycle, or back to a chronic injury. And it could, and that's what we're trying to stay away from, is basically get from an injury back to running as fast as we can. So that's why I'm doing this for the patients out there, for the docs. Hopefully you're following these guidelines and not, first of all, just saying, well, this is how I treat everybody. So we're, they come in, this is what they get. We got to figure out what's going on. We got to make sure, do they need to take time off? We really try to not have people take a lot of time off, because if you look at research again, keeping people moving, granted, sometimes we need to remove certain movements out of their regime for a while. Keeping people moving is going to increase outcomes. And then, the treatment of choice, or how good you can perform that treatment, is a big deal. So after we went through treatment, we get to actually, how do I get back to running in my sport? And that's called return to play, which I'm sure a lot of athletes and docs are familiar with. But I'm combining a return to play with also a baseline assessment. So let's say I have a runner who has had an ankle sprain out on the trail. We've went through all the necessary steps. Now we're at return to play. I think they're good to go. I've got to take them through some sort of battery of tests, or screens or capacity tests, something to see that they will be okay to start progressively loading into that pattern or that sport or movement of choice and not get hurt again, which that's also my responsibility, is to make sure that we're not injuring them by giving them basically the green light. So say I have an ankle, you could use anything like a broad jump, 2-minute jump rope, ski jumps, box rebound, single leg balance, whatever it is. I mean, depending on the injury, depending on the person, I don't have a set battery, right? I'm not a big fan of cookbooks and protocols. So I think you got to, if I have a 75-year-old, runner that's looking to get back to running a 5K versus a 20-year-old competitive ultra marathoner, totally different battery of tests to get them back to running. Some people may disagree with that. I don't know. But also, along with that return to play, I think it's absolutely crucial, and this is where I'm going to go off into the magic of hopefully trying to limit injuries once we get back to running, but that baseline assessment. So for us, that's going to be a functional movement screen. You can use whatever you want, but I really think you have to know how well is that person moving overall, which is very important for any sport. But now I'm going to go into how I would actually help a runner basically become, and this is our cheesy little slogan, better than before, but truly better than before, because if they come into my office, it's probably for a reason, unless they just had that freak accident. So there's probably something that we can improve upon, not just treat the injury. So if we get something like a functional movement screen, for those people that aren't familiar with it, it's basically 7 top-tier tests that we're looking at how you move overall to determine basically your readiness or preparedness to go out and perform loaded and variable tasks and whatever it is, sport. But we can use any one of those screening tests, and I'm going to use a toe touch as an example, to basically create a limiting factor when we return to running, rather than what most runners do is use their fitness level or aerobic capacity or endurance load as the limiting factor. So there are not many runners out there, and there's not, in my opinion, many running coaches that use mobility and stability as a limiting factor for returning to running after an injury, but also as a performance measure when we're trying to get a runner better, which I think is a huge deal. So how do you do something like that? Well, let's say I run somebody through a functional movement screen. One of the tests on there is an active straight leg raise. Basically lay on your back, keep your legs straight, lift as high as you can. Let's say they fail that, and we have them stand up, and then we go through multi-segmental flexion, which is just touching your toes. And the tip of your finger hits about mid-shin. And we do 2 or 3 basically warm-up drills or, corrective exercises, and we can improve, they're almost touching their toes. Okay, so we know we need to work on that pattern for a lot of reasons, and that's for debate why we're working on, full toe touch for any sport. But we know we can get it better. It's not just, hey, we got to go smash the hamstring or stretch for, the next 2 to 3 months. So if I can increase that toe touch, basically we know that we're removing threat from the brain. What we don't want to see is that when we get back to running, is that toe touch gets worse after I've done my corrective exercise, gets worse while I'm running. So there's a very hot debate around workout styles like CrossFit and whatever it is, that your workout should not cause damage and it should not leave you at the end of the workout worse off than you were at the beginning. I'm not here to talk about that. Maybe we'll do that on another Sunday night video. But in my opinion, if I go out and run and my mobility or stability, based on whatever test I'm working with, it's always a little bit of both. But let's say I do my warm-up drills, my correctives that I gave you or whoever doc you're working with, and before I take off to run, I can almost touch my toes, and about a mile in, I retest, and I'm back to mid-shin. I'm done for the day. And that's how we can start using, because any runner knows that we always have basically a gradual or a pyramidization of how we're getting to whatever our race volume or whatever we're trying to get to. But it's usually based on, speed or aerobic capacity, whatever it is, and we usually don't look at the movement of the body. But if your body or your brain starts to limit mobility, stability throughout your body, you're going to run back in injuries. So it's very easy to take something like a toe touch, tell a runner or whatever athlete and say, in the beginning, every half mile, you're going to stop, simply test your toe touch. If it's retracted or it's become worse, do your same correctives. If it gets better, you can take off and run another half mile. If you can't get it to go back to baseline, then you're done for the day. That's how we start capping a runner, especially post-injury, because, like I said, there's a reason that injury showed up if it's not acute in the first place. Now, I'm using a toe touch. That's got to be specific. You could figure out probably how to screen yourself. It's good to have an objective eye, but if you're a runner out there, you could probably do a couple movements and say, ooh, I want to warm up, this gets better, I'm going to use that as my test. But that's where I always, want to see people go see a professional, because it could just be as easy as getting screened or coming and do a quick, gait biomechanics assessment and saying, if your ankle dorsiflexion gets worse by 10 degrees by 2 miles into your run, you're going to start to affect everything up the entire kinematic chain, and that's not a good thing if we want to become a good runner, especially a distance runner of any volume. So that's how we would use basically this return to play cycle. But also, I think the biggest thing that I hope people take away from this is how you can use a parameter or a measurement like a mobility or a movement screen or whatever you want to call it to actually become a limiting factor, which is a big piece of the puzzle. And I think it's a piece of the puzzle that's been missed in, especially running, for a very long time. It's getting looked at a lot more now. But even at your elite levels, I don't think that you see a lot of people addressing movement is that the factor of like, hey, this is what's shutting down the workout today. It's always splits and, paces and, just overall rep schemes. I just don't think that, because that doesn't, if you equated that to anything else. So if we were in Olympic lifting and we saw somebody's form breakdown, we immediately, hopefully, we stop. But in running, how many people have been at a race and just see somebody that looks like they've never been taught how to run in their life because they're at the end of the race and they're just absolutely dying and they just keep going. And then they wonder why they're injured. And they look like, they're running downhill at 40 miles an hour on flat ground because they can't control any of their appendages. So if you guys have any questions about this, go ahead and comment on here or comment afterwards. Like I said, I'm going to put this video on YouTube. I'm going to put a little chart that I made in the comment section of this. You feel free to steal that, use it if you want. I hope you guys got some out of this. Like I do every time, I'm going to hang out for about 30 seconds or something and see if anybody's got any questions. What's up, John? Thanks, Patrick. And also, I mean, we could talk about this all night long, but Patrick just said he likes the timing of the functional screen kind of at the end of treatment. Depending on what somebody comes in with, we're also using maybe that functional movement screen at the beginning, because a lot of people come in, and if this is the case with you, this is something to consider. A lot of people come in and say, I only hurt when I run. If you only hurt when you run, there's a good chance that you have a running problem and not an injury. And I know that may seem kind of the same thing or hard to differentiate, but that doesn't necessarily mean that I'm going to look at how you run and try to change that. It probably means that you have a movement problem or some other, lack of mobility, stability, movement dysfunction, whatever you want to call it. There's something going on that's leading to pain or dysfunction while you're running. And we should definitely look at using mobility, stability, whatever, however you want to define that as a limiting factor in your workouts if you're running. All right, guys. Well, I'm going to get off here. I appreciate everybody for hanging out with me, and I will see you guys next Sunday.